Hi, I hope everybody can hear me. I'm Dr. Critchlow. Thanks for joining us this evening, this afternoon. It's a beautiful day, so hopefully we'll get this wrapped up and get some people outside because I think it's going to rain for the next forever. But we'll be talking about BPH, benign prostatic hyperplasia, which is the essentially what we call it when guys inevitably, as we get older, get trouble urinating. So we'll talk a little bit about what the prostate is, what it's supposed to do, what it can do to go wrong, talk about BPH briefly in general, talk about things we can do to work on that, sometimes including nothing, sometimes including some real surgery and a lot of things in between. So your prostate is a gland that sits essentially right where the bladder funnels. And so the first part of the outflow from the bladder, and the bladder is just a big bag of muscle. So your bladder, like your heart, is a big bag of muscle. Your bladder is meant to store your urine. And then when you're peeing, that bladder muscle contracts down, pushes the urine out of you. And so the prostate sits right where that bladder funnels. So you essentially pee through your prostate. In high school, prostates are about 15 to 18 grams in size. And all they do as time goes on is get bigger. And so most prostates end up, when guys are coming to see us, somewhere 40 to 80 grams or so. They can grow gargantuan, but prostates essentially just cause trouble as time goes on. What they're supposed to do, the function of the prostate is produce most of the fluid that comes out with ejaculation. Again, a lot of the medications and procedures we do can potentially affect that volume of ejaculate, but we'll talk about that a little bit when we talk about the specific things that we have to offer. So prostates can get bigger or tighter. That causes these urinary symptoms that most guys get. Prostates can get infected or inflamed. Prostates can get cancer. I'm not going to talk about prostate cancer. That's a whole different conversation. And it's important to remember that these BPH symptoms, stream getting weaker, not getting the bladder empty, getting up a couple times at night, those are not symptoms of prostate cancer. Those are symptoms of BPH. Prostate cancer usually doesn't have symptoms. The symptom of prostate cancer is a PSA that's going up too high. And BPH is what we call it when this prostate gets bigger and tighter and starts to cause symptoms. There's some technical things on this slide. Bladder outlet obstruction is a functional finding on some of our testing. Lower urinary tract symptoms are just the actual symptoms itself. BPH is the actual problem. So BPH is the pathological finding as prostates get a little bit bigger that leads to lower urinary tract symptoms. And again, BPH, these symptoms that we're going to be talking about are not prostate cancer. We screen for prostate cancer with a PSA blood test and usually a prostate exam every year or a couple of years. Generally, prostates get bigger over time, and generally that causes worse symptoms. I've seen a guy with a 300-gram prostate that was emptying out his bladder and sleeping through the night. So a big prostate doesn't always mean that this is a symptomatic problem, but generally as prostates get bigger, they cause more trouble. We usually break down symptoms, these lower urinary tract symptoms, into obstructive symptoms and irritative symptoms. So obstructive symptoms are from obstruction from the prostate. So weak stream, hesitancy, so standing there waiting for it to come out for 20 seconds, intermittency, the Kaminsky method, which is a funny show on Netflix, described that as Morse code. Pee a little bit, generate some more pressure, pee a little bit more. So those obstructive symptoms are generally from prostate. Irritative symptoms are generally because that bladder muscle, when it's obstructed, can get a little bit angry. Sometimes irritative symptoms come from dietary things like caffeine. A lot of times will cause these irritative symptoms, which are frequency and urgency. So normally people should be emptying out their bladder about every 3 hours or so. We say generally about every 2 to 4 hours. It's great if you can go 10 hours in between peeing, not good for your bladder. So about every 3 hours. But if you're peeing every hour, we call that frequency. Urgency is the sensation of I've got to pee, and oh my gosh, I've got to pee right this very second. And sometimes you can't get to the bathroom and you start peeing whether you want to or not. So those are irritative symptoms, frequency and urgency. And oftentimes they all go together because an obstructed bladder is irritable. This is a very common problem. 2 out of 3 guys on Medicare takes medications for their urination, and 90% of 80-year-olds take medications for their urination. That's Medicare data. Causes a lot of issues with sleep. With some guys get afraid to leave the house because they might have an accident. I hear all the time guys will say, "Hey, I know where every bathroom is when I'm driving to see my daughter in Columbia or whatever." So a common problem and causes some significant issues for guys. Talked about that. So again, on the left side, we're talking about PSA and DRE, which is the prostate exam, primarily to make sure that no significant concern for prostate cancer. There's all sorts of questionnaires we have folks fill out. These are the top one, the AUA symptom score or the IPSS. Those are basically the same thing. Those are validated questionnaires. And so that's how we track our response to treatment, whether that's pills or surgery. So there's always questionnaires to fill out when you come see a urologist. Depending on the specific indication, if we're talking about a procedure or a surgery, some of the testing that we'll do, sometimes we do flow studies. We can actually measure how strong the bladder squeezes down, make sure that the bladder's healthy in that regard. We can measure the flow rate. So with some physics calculations, we can tell whether somebody's functionally obstructed or not. Anatomically, oftentimes when we're getting ready to consider a prostate procedure, we'll get a size on the prostate because not every procedure fits every sized prostate. And oftentimes we'll do a scope where we look inside the bladder, put some numbing jelly in the urethra, put a scope up into the bladder to see how that prostate looks as the bladder's trying to empty. So generally before any sort of real treatment, we get a whole lot of information, both functionally and structurally. Again, extremely common problem, but guys don't have to do anything about this. We talk about watchful waiting. There are certain, some guys will ask me, do I need to be on a pill? And there are certain indications to treat this problem, whether that's with medications or with procedures. Some of those indications are you block up, can't pee at all, living with a catheter. Guys who are getting bladder infections, generally the biggest risk for getting a bladder infection is not getting the bladder empty, stagnant urine. I usually tell people that's kind of like an upturned bucket of water in the summer. Bacteria love that. So bladder infections, bladder stones. Some guys will form a bladder stone because they're not getting the bladder empty enough. Some guys show up in the ER with 4 liters in their bladder and renal failure. And sometimes that pressure in the bladder can back up and hurt the kidneys. So there are certainly indications where we say, hey, you're hurting yourself. We need to do something about this. But short those things, this is usually a quality of life issue. So when guys are asking me, hey, do I have to take this pill? Do I need to do this? It's really up to how much this bothers you. Most guys are going to get some bothersome urination as time goes on. Getting up once or twice at night, peeing every couple hours, if that doesn't bother you, and we check all these other things, no infections, et cetera, then you don't have to do anything about this. But the pills that we have, which we'll talk about, and the procedures that we have, really do make a pretty big quality of life improvement for most people. Talk about all these things. A lot of guys ask me about supplements, and my general thought about supplements is that if saw palmetto or whatever it is that's in the super beta prostate health max things that you can get at GNC, if that worked as well as Flomax, Pfizer would have put that in a pill. So there's a little bit of data about saw palmetto. So saw palmetto is probably okay. Basically, every prostate supplement is just saw palmetto and then a couple other things to make it different from the one next to it on the shelf. But they don't have a big impact. And what I usually tell guys is they might help you a little bit, probably not going to hurt you, but we have things that we know help. So in watchful waiting, we talk about trying to limit fluids before bed. We talk about trying to limit dietary irritants like caffeine and alcohol. Those things are known to make that bladder more irritable. And oftentimes we can make improvements without pills or surgeries. But this is usually a progressive problem, meaning that most guys who are 40 don't have a lot of trouble peeing. Almost every guy that's 70 has trouble peeing. So this problem just marches forward. So we can make some changes and try to help with the getting up at night and the irritative symptoms like from caffeine, for example. But again, this is almost an inevitability that guys end up on either pills or having a procedure. So the medication that we almost always start with is Flomax, tamsulosin. There's a couple different medications in this class: alfuzacin, which is uroxetrol, and silodosin, which is Rapaflo, but they're all basically the same thing. They're alpha blockers. And what they do is basically relax the prostate, so it's not clamped down so tightly. They work quickly, and you take the pill on Monday, and by Tuesday, you're generally peeing much better. These medications are meant to be taken every day forever. You stop them whenever you want, but then the symptoms are going to come back. And I have guys on Flomax who, they'll go on a weekend trip somewhere, forget their pills, and they're really hurting. So the medications are effective when you're taking them, but the effectiveness can wear off pretty quickly. Common side effects: some guys will get a little bit lightheaded when you stand up from a chair too quickly. About 20% chance of causing retrograde ejaculation. So it shouldn't affect ability to get an erection, but with orgasm, sometimes nothing or less will come out. Again, anything we do to affect the prostate can affect that, because that's the prostate's job. And those aren't permanent sort of things, but Flomax is what we almost always start with. Works quickly, effective, old, cheap, generic pill. The other medication that's very commonly prescribed with Flomax, tamsulosin, is finasteride or dutasteride. Finasteride, again, old, cheap, generic pill, been around for decades, been used in tens of millions of guys. It's the exact same medication in Propecia. And what finasteride does is shrink the prostate. So tamsulosin, Flomax, relaxes the prostate a little bit. Finasteride actually shrinks it. Finasteride takes 6 to 12 months to work, but after that period, after 6 to 12 months, finasteride actually decreases the chance that a guy will block up totally and end up in the ER needing a catheter. It's the only pill that's been shown to do that. Finasteride also decreases the chance that guys need a surgery by about 50%. So sometimes guys will ask me, I never want a prostate surgery in my life. Is there anything I can do? And finasteride is the answer to that. It's the only pill that's been shown to do that, because it actually addresses the problem, which is a growing bit oversized prostate. About 5% of guys will get some sexual side effects with this, maybe some erection problems, maybe less ejaculate like the Flomax, maybe trouble with interest in sex. Most guys don't have any side effects. And again, it's the same medication in Propecia. So some guys will notice that they get a little bit more hair. So those are essentially the two most common medications that we use. The other one I'll mention is Cialis, daily tadalafil. Cialis is an erectile dysfunction medication that's recently gone generic in the past couple of years. It is FDA approved to take in a low daily dose at 5 milligrams a day. And that helps with the urine flow. So that's the third class of medications that we use for this problem. Cialis is generic now. Some insurances cover it, some don't. We sell it for $50 a month for cash. So some guys will say, I went to Walgreens, my insurance doesn't cover it, it's $400, but the most you'd ever pay is $50 a month for the daily Cialis. Nice for erections because it helps with that. Nice for urine flow as well. Those are the three classes of medications that we use. The most effective medical therapy for this problem is tamsulosin and finasteride together. So procedures. We'll start with Resume. I'm a big fan of Resume. Resume is something we do in the office. So no general anesthesia, no hospital. We numb everything up pretty effectively. A lot of lidocaine, ultrasound probe. We inject lidocaine into the prostate, like when we do a biopsy. We put lidocaine jelly in the urethra. I usually let all that sit for about 20 minutes. And then the procedure itself takes about 5 minutes or so. And essentially what Resume is through a scope, where that chunky obstructing prostate tissue is, through the scope, we can deploy a needle out into that tissue, and over 9 seconds, we deliver hot steam into that part of the prostate that we're targeting. That causes that part of the prostate that we're targeting to shrivel up and die. And so that shrinks the prostate, destroys part of the prostate, opens up the channel really nicely with no permanent implants, no sexual dysfunction, and no general anesthesia. Has FDA approval for prostates between 30 and 80 grams. Resume has data showing that it works great for bigger prostates. 120 gram prostates, Resume works really well for, but currently it's approved up to 80 grams. Some insurances will just cover it, carte blanche. Some, if they see that a prostate's over 80 grams, sometimes it'll be cash if it's not covered. But I think our cash price is $2,000 or $3,000, so it's not like getting your knee replaced. But usually it's a covered thing. Catheter after a Resume for about 5 days or so as everything's healing on the inside. And what I usually tell guys is for a couple of weeks after that, things will be a little bit irritable as everything's settling down on the inside, burning, stinging, urgency. And then usually by a month, guys are doing really well. By 3 months, guys are doing great. The 5-year retreatment rate is 4.4%. It's less than 5%. So in other words, 19 out of 20 guys, 5 years, do not need another procedure, which is pretty good for something we can do in the office. I think this is a video. Last time, I don't think the audio played, but let me see. Yeah. So Brittany tells me you can't hear this. But again, the video showing this scope, and you can watch on the monitor if you want. Some guys like to watch, some guys like to close their eyes and wait till it's over. Scope goes through and we basically steam that chunky part of the prostate to get it shriveled up and the channel opened up. No sexual side effects, no general anesthetic. Yeah, some guys choose to do this because their symptoms are getting worse beyond the medications. Some guys choose to do this because they don't want to take their pills anymore. Some guys choose to do this because they know that if they don't do anything, it's just going to get worse, and they don't want to wait until they need, more like a real surgery. But I've been very happy with Resume. 97% would recommend it to to a friend. I'm not going to talk through Joe's story, but Joe's another happy Resume customer. Joe's doing great. Look how happy Joe is. Urolift is the other what's considered minimally invasive procedure. We do Urolift with a little bit of IV sedation, like a colonoscopy. Some urologists are losing a little bit of favor with Urolift. Works well initially, and retreatment rates is starting to creep up there in the real world studies. But Urolift is best, in my opinion, for smaller prostates, kind of the 30 to 50 gram size. So Urolift, we basically go in through the urethra and push those lateral chunks of prostate, push them out of the way to open up the channel that way. So Urolift doesn't actually destroy any prostate tissue. If you got 50 grams of prostate before, you're going to have 50 grams afterwards. It's just moved out of the way a little bit. And it's kind of like if you have a double panel curtain, pulling the curtains back, so you can see through the window a little bit better. And so that's my best analogy for a Urolift. We again staple the prostate back. So there are permanent implants there. They've been studied. They're safe. They don't cause trouble. They don't set off airport metal detectors. And again, for a couple of weeks afterwards, no matter what we do to the prostate, you can have some irritative symptoms, burning, stinging, that sort of thing. Urolift is very commonly done. It's another option for a lot of guys for whom Resume is an option. In a blind vacuum, without knowing anything about a specific guy, I tend to favor Resume a little bit, but both are very common procedures. Green light, I don't do personally. I've seen some trouble with worsening irritative symptoms, that burning, stinging, urgency sort of problem. But green light's a common procedure that's done. This is done under general anesthesia. So scope goes in the urethra, and where that obstructing prostate tissue is, instead of steaming it and causing it to die, instead of pushing it out of the way, we can aim a laser at it and vaporize it. So general anesthesia, some guys stay overnight, one night, some guys go home the same day, usually catheter for a day or two or three. And then retreatment rates pretty minimal. Anytime we're using energy, like laser or cautery with a TURP, scar tissue can be a problem. We've seen that a couple times. A few of my partners do green light and like it. I don't do it because I think there's a better way to treat prostates. I will show a couple parts of this video because it shows a reasonable cartoon of the prostate channel. So bladder's up above us now, urethra's down below. And so with a green light, with a Resume, we go in, and instead of shooting a laser at the tissue, we deploy a needle out into that and destroy it that way. Urolift just pushes that tissue out of the way. So again, for reference, we're looking up towards the bladder on that last image. So bladder's through that hole, and that's all the stuff you're trying to pee through. And so a green light just vaporizes it. And so you can see wide open channel, which is the goal of any of the procedures, whether that uses a green light or a staple or a steam or whatever. It's just to open up that channel and get guys peeing better. Historically, that's been done with a TURP, which is a quote unquote roto-rooter. That's been done since the 1800s. A little wire loop that we run some current through, and we just carve open that channel. We cut away a lot of that prostate tissue. This is the gold standard because they're way over 100 years of track record. Done under general anesthesia, sometimes home same day, sometimes one night in the hospital, usually catheter for 2 or 3 days. TURP has a very small chance of causing some trouble with erections, maybe 2 or 3% will have some erectile dysfunction afterwards. TURP will take away the ejaculate. Again, most of what we do does that. I should have mentioned Urolift and Resume basically have no sexual dysfunction whatsoever. They should not change the ejaculate volume. They should not change the erections. TURP will take away ejaculate, the fluid. Very small chance of affecting erections, but it's possible. And scar tissue is a potential problem with any of our procedures. TURP's being done less and less because there are easier options which achieve most of the same goal. Although again, if you want something that's not new in the past 2 decades, TURP. This is an outdated slide. Nobody does a simple prostatectomy in St. Louis anymore because I do a HOLEP, which Brittany mentioned earlier. HOLEP is essentially a simple prostatectomy just done through the urethra. HOLEP stands for holmium laser enucleation of the prostate. If your prostate's like an orange that you're peeing through, with a HOLEP, we go in and shell out all the pulp. Lifetime retreatment rate is less than 1%. No more ejaculate forever. Because the channel is so wide open after a HOLEP, guys leak at the beginning, so pads or diapers, almost universal the day after catheter comes out, and that goes away. So 75% of guys are dry by 3 months, 99% by a year. So HOLEP is the recommended surgery from the American Urologic Association for big prostates, big being over 80 grams or so, some guys have a bladder that we know doesn't work at all. That bladder muscle doesn't squeeze, and they're cathing or living with a catheter and don't want to anymore. HOLEP's about the only guaranteed surgery that'll do that. So for guys who have really big prostates or want to have one thing where they never have to worry about their prostate again, that's a HOLEP. I was the first one to do HOLEP in St. Louis. I do the most in St. Louis. There's one other guy that does HOLEP in St. Louis now, Dr. Nottingham at WashU. But that's more of a specialized sort of surgery. We always authorize these things. You know, sometimes an insurance company will make us get a certain test or whatever, and we jump through those hoops, which is unfortunately something that we have to do. But we always get things covered before we do anything, and most of these things are covered. So again, to summarize, prostate's a gland, makes ejaculate, can cause trouble either with urination, with cancer, or can get infected. This talk's been about the urination standpoint. As long as there aren't a couple things going on, stones, infections, bladder or kidney damage, then it's entirely elective whether we treat this or not. So keeping an eye on things reasonable. If guys are starting to get bothered, pills, tamsulosin, Flomax, finasteride, Proscar, tadalafil, Cialis are the 3 medications that we commonly use, either alone or in combination. Resume and Urolift are the minimally invasive, quick and easy 5-minute procedures. And then if we're talking about real surgery under general anesthesia, usually a TURP or really in the contemporary times, a HOLEP. So I don't know if any of you guys are my patients or who urologists you guys are seeing, but certainly, I mean, most guys in their 60s and 70s, very reasonable to have a urologist because, you know, kidney stones pop up, prostate cancer pops up, urinary trouble pops up, trouble with erections pop up. And so Urology of St. Louis, there's 27 of us. We're the biggest group in town, or one of the biggest groups in the Midwest. Any of us, I think all my partners are fantastic doctors. So any of us would be happy to see you for any of those problems. And I think that is it.